started with A, Arumugam Nagarsivam, and it is going to end with Z, Zahir. So he opened with perfusion, not touching the patient. Now Zakir will open our brain by doing surgical expertise and he will show all of his expertise. But I want to tell about Zakir also. We met him long back, only ever to meet him. And recently his daughter has got some prize in Thailand, Taiwan. Okay, he has done new international surgeries and all it seems. Let us have his speech now.
Thank you. Thank you. Thank you everyone. And I moved to the UK after finishing my MCH neurosurgery in Chennai, and then I was there in UK for 6 years, then moved to New Zealand, started a new unit along with my colleagues, and I also run the International Neuroradiology Service in New Zealand. So where we are located is in the North Island of New Zealand, and if you can see, our hospital is serves a population of about 900,000. The whole population of New Zealand is only around 4 million. And this is our hospital. We serve 900,000 population. And stroke, we're not fully fledged with stroke management as Nalasaram does. We have a stroke team, but because of the geography of New Zealand, it is hard to move patients within 4-hour or 6-hour time period to the hospital. So most of my stroke practice revolves around patients who come into the hospital or who are already in the hospital with a stroke. And these are the 5 trials which I mentioned here which changed the practice of stroke. And the Extend IA trial is a famous trial from Australia and New Zealand which we were part of, and that also helped to prove that mechanical thrombectomy is superior to reperfuse the brain. So when do we treat stroke patients? The inclusion criteria is any acute patient who comes with a stroke, like symptoms, you need to do a CT scan. A CT scan should not show any hemorrhage, and it should not show an established infarct. The infarct may be not picked up within 24 hours. It's usually a CT scan picks up an established infarct only after 24 hours. So we do a CT angiogram and a CT perfusion. I always do a CT perfusion to look at the penumbra. I'll explain to you what is a penumbra. Sometimes I get patients from the cardiology unit who work next door to me and they have an embolus, and then we don't have time to do a CT angio, so we immediately do a catheter angiogram and look at the site of the occlusion. Our angio machine has the capability of doing a CT-like image, so we don't take them to a CT immediately if we do the patient in a cath lab. If it's a posterior circulation stroke, then we have to make sure that the patient has intact brainstem reflexes before intubation for stroke thrombolysis. Exclusion criteria, as we said, if it's a large infarct or hemorrhage, we don't treat those patients. And if it's an elderly patient above 80, 85, I'm a bit hesitant to take those patients for stroke treatment unless they have a good pre-morbid history. What is an ischemic zones in a stroke? I mean, as you look at it, immediately adjacent to the site of the block, you get a small area of infarction. And the rest is the penumbra. What we are trying to achieve by reperfusing, by removing the clot, is trying to preserve the penumbra. What the penumbra is, the penumbra survives on the parietal circulation from the rest of the brain, especially if it's an MCA infarct. The penumbra is the parietal circulation, the bile collaterals from the anterior cerebral artery, trying to perfuse this part of the brain, but this is not adequate. So as time goes by, this becomes an acute infarct. So CT perfusion or an MRI scan with the diffusion weighted image can tell us the amount of penumbra. If it is less than 70 cc on an MRI brain, then the patient can be salvageable. So if you look at this, I'm giving you the parameters which we normally calculate in the CT perfusion. In a normal brain, the cerebral blood flow is about 35 to 60 ml, depending on whether it's gray matter or white matter. Okay? Cerebral volume is 2 to 4 ml. If the patient is infarct, there is gross reduction in cerebral blood flow and cerebral blood volume. But in the penumbra, there is only moderate reduction in the cerebral blood flow, but the blood volume is normal or increased. So there is a mismatch. This is what you see in a CT perfusion. So if there is a mismatch, then you go ahead and do a stroke thrombectomy. Endovascular therapy, we divide the circle of Willis into anterior circulation, that is from here, this is anterior circulation. The anterior cerebral artery, middle cerebral artery, internal carotid artery. Posterior circulation is both the vertebral arteries and the basilar artery, posterior cerebral arteries. So time window for treatment of patients with anterior circulation stroke is 4 to 6 hours. So predominantly, I mean, we look at 4 to 4.5 hours. If it is more than 4.5 hours, we try to do a diffusion weighted image on an MR, which takes nearly 30 to 40 minutes. And then if it is salvageable brain, then we go ahead and do a mechanical thrombectomy. In a posterior circulation stroke, that is posterior cerebral artery or the basilar or vertebral artery, you've got a time window of 10 to 12 hours where you have time to work on these patients with IV thrombolysis first. If it fails, then you go ahead with mechanical thrombectomy. So these are the candidates who are likely to benefit. That is, for anterior circulation, it is 4 to 6 hours. For the posterior circulation, it's up to 12 hours. And CT should not show an established infarct or a bleed. The MRI diffusion weighted volume should be less than 70 cc. If it is more than 4.5 hours, do an MRI scan to see if the diffusion weighted volume is less than 70 cc. And if the patient is younger age, they do well. More than 80 years, I mean, they should be in a good pre-morbid condition. They really don't do well. So I prefer not to offer mechanical thrombectomy for these patients. Moreover, they have very tortuous anatomy. It is difficult to navigate catheters in very tortuous anatomy. They cause more harm than good. And they should have a good life expectancy. They should not have other medical conditions like cancer or anything. So we look into all those comorbidities before we consider mechanical thrombectomy. So this is the algorithm which we follow. A patient comes to the ED, I think Nalasan was already mentioned, do a plain CT head. Again, look for hemorrhage or an infarct. If there is hemorrhage or infarct, you don't go ahead. If there is no hemorrhage or infarct, you do a CT angiogram to see the site of occlusion, whether it's the internal carotid artery or the middle cerebral artery or the posterior cerebral artery, whatever. If it is positive, then you go ahead directly to endovascular therapy. If it is more than 4.5 hours, then you do a diffusion weighted MRI image. And if the diffusion weighted volume is less than 70 mm, then you go ahead and do endovascular therapy. If it is more than 70 mm, they don't do really well. So this is the endovascular techniques which has evolved over time. I will go through one by one. Initially, they used to give IV thrombolysis. If it fails, we used to pass a catheter into the clot and give RTPA or urokinase, which is still risky because there is high risk of hemorrhagic transformation of the stroke. Then we had the clot retrieval device, which this is called a Mercy device. It's like a spring, and it had microwires which used to entangle within the clot, and they tried to pull it. This didn't work well because the design of this clot retrieval device was not very good. And then came the alligator device, which is like a claw going to grasp the clot, but the clot used to break, and this also failed. This device is called the penumbra aspiration device, which is still used. What we do is we pass this part of the device, pass the clot and break the clot, and there is we can use a 50 cc syringe and aspirate the clot through this catheter, or we can connect it to a mechanical aspirator and break the clot. And we pull the clot as we aspirate and then pull the whole system out. This is still used, and I mean, I don't normally use this system. I use a different system. If there is associated atherosclerosis, we dilate that part with a balloon, and it's called angioplasty, which the cardiologists normally do, and we use special stents to keep it open. This works sometimes, but these vessels are not as cardiac vessels. The brain vessels they behave differently. While dilating with a balloon, sometimes the vessel ruptures completely, the patient dies on the day. So we rarely use this type of technique. This is what we commonly use. So this is a clot. We pass a microcatheter past the clot and deploy the stent. This is called the solitaire stent. When it opens up, the clot gets entangled within the interstices of the stent, and then we leave it open for 5 minutes, and then we slowly pull. At the same time, we use a 50 cc syringe and aspirate the guide catheter. This helps most of the time, and this is commonly practiced. Now we have a different stent called the Trevo stent, which is also useful. So this is how it pulls the clot. Sometimes you get little plaques entangled within the interstices, and this is a clot which will be retrieved. And this is how the stent looks like. If you want, you can use that stent. It can be detached at this zone. So this is a detachable stent. If there is stenosis, after removing the clot, you can detach the stent where there is stenosis to keep the vessel open. And this device is nothing but a kind of a basket. It's called the catch device from valve. You deploy it beyond the clot and open up the basket and try to catch the clot and flow. This is how a modern angio suite should look like. So this is where a CT scan is available. Patient is wheeled in from the emergency department. The CT is done. If there is no hemorrhage or there is no established infarct, IV thrombolysis is given on the table, or you take the patient directly for mechanical thrombectomy. This is how the modern CT angio suite is going to look like in the next few years. I'll show you some examples of clots which I have removed. This is a case of basilar artery thrombosis. You can see these are the vertebral arteries, intracranial segment of the vertebral artery. This is where they join and form the basilar artery. There is no flow distal. Patient had a 12-hour time window. Patient was in hospital. I think he came to our unit 8 hours. We did a cerebral angiogram. This was the picture, and I passed a stent. So this is where the initial start of the clot was. This is the distal part of the stent. So I deployed the stent, left it open for 5 minutes, and then the stent started opening and it got hold of some clot beds, and then you have to repeat the procedure again and again. Each stent can be used for 3 or 4 times. Sometimes it can detach, so you have to do it again and again. And this is the final picture. So you open the basilar artery, that is the stent which is left deployed. You can see that both the posterior cerebral arteries open, this is the superior cerebral artery which is open. And this patient had a very good outcome. This is again another case of a vertebrovascular stroke. Again, there is no flow passed into the basilar artery. There was a stenosis already with an atheromatous plaque. So we used a stent to retrieve the clot, and then I deployed the stent there. And after deployment, that's the tip of the stent, that's the distal end of the stent, this is the proximal end of the stent, and that's the narrowing of the basilar artery, of the vertebral artery. This patient also did well. And this is a post-cardiac surgery valve replacement. Patient was on antiplatelet drugs, presented with an MCA stroke. So this is the internal carotid artery, anterior cerebral artery, this is the middle cerebral artery, there is a block here. In this case, I used the stent, this is the solitaire stent, did pass distal to the clot, left it open for more than 5 minutes. The clot did not come. It only partially opened up a vessel. The clot did not come, there is still a blockage there. So I had to use a different technique. I used a hyper-compliant balloon. This balloon, you can see it opens up distally and proximally. There is a narrowing there. So that is where the block is. So I tried to fish out the clot using a balloon. And after that, that segment opened up. The material was removed. And this was the post-op CT. Patient had a hypoperfusion, but this improved. He went to rehab and he had a good outcome after about 6 months. This is again another patient came in after carotid endarterectomy. This patient was wheeled in. We didn't even go to a CT. This is a CT-like image which we can perform in our angio machine. And this patient had a stroke on the left side of the middle cerebral artery. There's a blockage there. Again, past the stent, past the blockage, there's a distal aspect of the stent. Some of the branches opened up, but still there is no perfusion. We used a balloon, this is the balloon catheter. And again, that branch started to open up, and this is the final result. And this is the post-op CT. You can see the amount of infarction is not much. This is the most recent patient which failed IV thrombolysis, was within 3 hours of symptoms. I used a different stent, this is called a Trevo stent, which cuts through the clot, and it is radiolucent, it is radiopaque. You see the whole segment of the stent. This patient did well, and this is the final result after opening up the clot. After all my procedures, I always put these patients on aspirin 100 milligram per day, usually lifelong, but I leave to the neurologist or stroke team physicians to decide on what antiplatelet drugs they want. This is a patient who presented with only a TIA, not a stroke. It was due to an aneurysm here. This is a vertebral artery aneurysm. The patient had repeated TIAs, was on antiplatelet drugs. His PFA, everything was fine. So I decided to stent this patient. I placed a stent across the aneurysm. The aneurysm is here. I placed a stent, and then I coiled the aneurysm through a stent, and the symptoms completely improved. So this is a stented and coiled aneurysm. So TIAs can happen with tiny aneurysms too. So you get favorable outcomes in endovascular therapy in about 52%. There is successful reperfusion in about 67%. There is a mortality related to the procedure, which is about 17%, but if left alone, these patients can die. The mortality is more than 25%. Symptomatic hemorrhage after reperfusion can happen in 2.5%, and asymptomatic hemorrhage is about 27.5%, which usually these patients recover well. I'll go through the neurosurgical aspects of stroke. As a neurosurgeon, patients with stroke develop severe cerebral edema. They become slowly comatose, and they end up in the ICU. What we do is we take these patients, put on ICP board, do a CT scan. It is severe mass effect. We perform decompressive craniectomy. What we do is we remove the bone flap and leave it to the neurologist to manage the ICP. So all stroke patients go to the ICU. We do ICP monitoring. If they don't respond with mannitol or hypotonic saline, then surgical decompression is offered. Usually surgical decompression is offered only for young patients, not for elderly patients. If it is a non-dominant hemisphere stroke with mass effect, in non-dominant hemisphere stroke with mass effect, we offer surgical decompression. If it is a dominant hemisphere stroke with preserved language function, then we offer decompression. If it is a posterior circulation stroke with mass effect, then we offer decompression and place an external ventricular drain. So this is an example of a cerebellar stroke where the patient presented with hydrocephalus. You see the dilated temporal horns, dilated third ventricle, and squashed fourth ventricle. So we had to place an external ventricular drain because there was obstruction at the aqueduct because of the cerebellar swelling. So we place a drain into the ventricle, decompress the brain, and then we do a posterior fossa decompression. So we do a midline incision, expose the occipital bone, open the dura, and then close it with muscle and skin. So it is just a life-saving procedure, and they usually recover. This is a patient with a massive MCA stroke. You can see the amount of midline shift. The ipsilateral ventricles are squashed. The massive MCA stroke. IV thrombolysis and mechanical thrombectomy failed. But he was a young patient, so what we did was we removed the bone. It's the immediate post-operative period. There's a lot of brain swelling. Brain is herniating to this effect. But after 3 to 4 months, When everything settles down, the brain retracts. There is encephalomalacia here. And we plan to put the bone flap back. This is a CT scan which we normally do. The 3D CT after a decompression. And we put the bone flap back after 3 to 4 months. Suppose if the bone flap is not viable or gets infected, then we do what is called an artificial bone flap. This is made out of 3D printing, made out of PEEK material, sometimes it's made of acrylic, or we even use titanium. So this we do after 3 to 6 months, and the underlying brain is protected. So decompressive craniectomy also has its side effects. Hemorrhagic transformation of a stroke can happen, infection, delayed wound healing, or the patient can develop hydrocephalus or CSF hygroma or fistula. Some of these patients have a sunken bone flap because due to the atmospheric pressure, there's a lot of pressure on the brain. Unless you put the bone flap back, they'll have language problems, memory problems, even hydrocephalus. So we try to treat these patients early by replacing the bone flap. So there are some unanswered questions regarding decompressive craniectomy. We don't know which group of patients will improve or who will have a good functional dependency and what is the optimal timing for surgery. So these are unanswered questions which only time will tell or any randomized trial will help us. So the basic take-home message is if a patient comes with a stroke, a CT is a must. CT with CTA brain. You can do a CT perfusion, that will be helpful. Main purpose of this talk is you need to do a CT to rule out hemorrhage or established infarct and identify the site of occlusion. On the CT table, if you find it is ideal to give IV thrombolysis, then the stroke team will take over and they do IV thrombolysis. Endovascular therapy is useful in anterior circulation stroke within 4 to 6 hours. But in posterior circulation stroke, you have more time window to work on. So try IV thrombolysis for up to 8 hours and then endovascular therapy can be tried. If these patients deteriorate with mass effect, then decompressive craniectomy can be performed in young patients who are eligible to save their life. Thank you.
How early you perform this decompressive?
Patients who deteriorate, usually they don't deteriorate that fast. The stroke patient, they manage it by the stroke team. If they deteriorate, becoming more hemiplegic, more comatose, the GCS, Glasgow Coma Scale, goes down. Then we do a repeat scan. We look at the mass effect, the severe mass effect, immediately.
So it's more of a symptom-based treatment rather than evidence-based treatment.
So symptom has to correlate with the CT.
I mean, it saves the patient, but not the cost of disability. Without craniectomy, the malignant MCA informed, they will die. So we had 3 patients who had a craniectomy, all young patients, because the guidance says it's less than 55, isn't it? Is it 55? Age is 55 is the cutoff. Craniectomy.
Craniectomy, I mean, we even go up to
What do you consider as young? You said young patient.
young patient. Okay, we are young.
55 is younger. 55 is younger.
So always we are young. Even at 60 we are young.
I mean, they have about 75 years old.
So because of the pressure on the brain, they have to remove it, otherwise the patient won't survive. But they'll definitely have severe disability for life. Is that true?
Severe disability.
For
I
life.
mean, that infarct is there. Patient already has an infarct. But if it's a non-dominant hemisphere, he can survive with that. He can have a reasonable quality of life with some assistance.
What's the question? I mean, you just mentioned about the patient's speech function has to be preserved for left hemispheric stroke. Why is that?
If the patient has, sometimes the language area need not be exactly where it should be in a right-handed person. Okay, you do an MR, what's that?
DW.
Functional MRI, then you'll know where the language function is. Okay. So even with an MCA stroke on the left hemisphere, they can still have preserved speech.
But the idea is to save the patient, isn't it? So why you don't exclude those patients?
Language function is critical. It's critical. I mean, that is the protocol we are following in our hospital.
The other question is, the CT perfusion you mentioned about. Because we do start IV thrombolysis, do CT angiogram, see if there's a block, send the patient, they put a catheter. So the CT perfusion takes some extra time. So there's
10
no,
minutes.
Yeah, but there's no evidence that.
CT perfusion is helpful mainly if the time window is around 3 to 4 hours, we don't know. You see the amount of penumbra. CT perfusion is useful for the penumbra. MR is the best, but MR takes 45 minutes.
You mentioned something about the Triffin syndrome, the Triffin.
Syndrome of the Triffin.
Yeah. Could you just elaborate?
Okay, what we do is when we remove, normally the atmospheric pressure does not influence the brain because your skull is there. When you remove the skull, when there's no brain swelling, the atmospheric pressure presses on the scalp and you get a sunken appearance. That some people don't tolerate because there is mass effect. If it's on the left side, the language function is affected, the memory is affected, speech, everything is affected. Even they can be hemiplegic. But if you put the bone flap back, it improves.
What's the long-term prognosis or survival after these procedures, especially with regards to craniotomy?
Craniotomy, it's a common procedure. Those days we thought craniotomy is bad. It's a very common procedure. We can do it very safely.
It's not the craniectomy that determines the prognosis, it's the stroke. It's called what we call as a malignant stroke. It's a huge part of the hemisphere is involved.
MCL.
So without surgery, they will die because of the edema on stomach.
Yeah.
So they have to open up. So the prognosis is long term. You'll have to get disability.
They will have
Disability is there
disability.
because of the stroke. Not
Yeah.
because of the brain.
Okay. This is basically a life-saving.
To save life, that's all. Unless the thing is complicated by infection. If you're doing surgery, infection can happen. But otherwise, it's stroke which is causing the disability.
Yeah. Even though the guidance says about less than 55 years for a craniotomy, I think in my experience I've seen same amount of stroke. Older patients do better, they survive better without craniotomy. Any idea why?
The brain volume is less.
Same, yeah. They got more space to expand. So they survive without craniotomy. Whereas younger patients, there's no space to expand. The brain is still perfect.
They are used
So they
to their
need to
brains.
have open to survive it. So shrunken brain is better.
I had a question before that. For you, another scope. I am working on adolescent population. You are working on adolescent. I am working in this
Super.
only on adolescent population. I am working. I haven't stopped. So from my experience, what we can tell about how to prevent this kind of CVAs, not only in the later part of stage. Apart from smoking, what are other preventive measures?
All this, there's no role for primary prevention in the sense, not had a TIA or stroke, we don't give any. Similar like cardiology patients, we don't give any antiplatelets. It's all the blood pressure control, bring it below 140 or 890 something. Treat the diabetes perfectly, treat the hypertension, start on statin if his cholesterol is high. So that will go a long way. Because stroke thrombolysis is not going to be happening every part of the world. In government hospitals, it may take years to establish the service, not to undermine the government service, but it's a practicality of it. So the prevention in our population is better than, yes, we need to have stroke thrombolysis, but we need to prevent this patient's thromboembolize. So I think it's all addressing the atherosclerosis, like treat hypertension, treat diabetes, stop smoking, treat cholesterol. I think that's, you see that in patients.
But what I say is we are not giving much importance to this kind of particular series in schools. What kind of diet you are based on this?
Diet?
Diet.
Oh, I think maybe Premlata can advise more on that.
Because
I think as I said, the one thing I said about statin treatment is, it's not a cholesterol reducing effect alone. It stops the plaque rupturing. It's reduced inflammation and atherosclerotic plaque itself. So even if somebody is having a normal cholesterol, they had a TIA or stroke, you need to put on statin.
more of curative.
Yeah. Primary prevention, there is no role on that.
கிளாஸ்ல கேட்ட கேள்வியோட அதிகமா கேள்வி கேட்டீங்க
Class ல ஒண்ணுமே படிக்கல.
Class ல கேள்வியே கேட்டது.
Class ல தான் கேக்குறீங்க. class ல வரல.
So, very wonderful CME today we had. Both the speakers have done a lot of homework.
Highest attendance.
Yeah, this is the highest attendance we have ever had for a CME. That shows the popularity both of you enjoy. And the lady crowd is higher than the men crowd. Okay,
So
so
one thing I just want to mention is Zakir, we worked in UK for 10 years now. We used to work together, not in the same hospital, but close to home. I think he's done a fantastic job. You know, he's not showing off now. He has been doing lots of publications in UK. So me and Vijay used to call him as paper boy.
And I would like to welcome a special EGN today. Today is the initiation ceremony for Mayataj. Mayataj, would you please get up?
Everybody knows.
Would you please get up, please? Yeah.
We want her
Yeah,
number.
yeah, please come over
We
here.
want her number.
Come over here. Mayataj, come over here. Sendil has taken very great efforts to track Mahartaj. With a lot of effort that you have been tracked and traced. And would you like to say a few words?
EG world.